Welcome back, everybody. My name again is Dr. Khan Kao. I am joined by Dr. Ati Hakimi, who will be talking to us regarding family practice or family medicine. Welcome, Dr. Ati Hakimi.
Thank you so much. I'm so happy to be here.
Thank you for joining us. She has over 15 years of practicing in medicine, so she'll be giving us an extensive good advice regarding family medicine. Um, so,
Hope
uh,
so.
sorry about that. Go ahead.
No, I said I hope so.
Yes. We'll start. Let me just give a little bit about background about who you are and how you got into family medicine, and then maybe a little bit about the job description of family medicine.
Yeah, sure. I actually went to medical school a long time ago, and I actually chose a different route. I went to the Caribbean for medical school.
Mhm.
The way that works is that back in the 90s, it was still super competitive to get in, and I was a little bit older, so I just didn't want to wait. And I just went straight for the Caribbean option. So I ended up going to the American University of the Caribbean, that was on the island of St. Martin. And I did that for 2 years for my basic sciences. And then I transferred out of that to another school so that I could do my clinicals in the US.
Mhm.
So I ended up going to Chicago, Illinois, and I did my clinical medicine in a hospital called Jackson Park in the south side of Chicago.
Mhm.
And from there, I actually just stayed there and got into a family medicine residency with Northwestern
Mhm.
and did 3 years with them. When I was doing my different rotations, I fell in love with the seniors. I guess it was because I never had grandparents growing up. So it was kind of just like that. It felt like, good old fashioned medicine where they respected me and I respected them. And I really fell in love with it. So I ended up doing like a geriatrics fellowship as well,
Oh.
for a year after my family medicine. The reason I chose family medicine, with all due respect to my peers and colleagues, is I felt like that was the real doctor, right? So we got to know a little bit about everything, and we got to know everything from beginning of life to end of life care. So that kind of empowered me to feel like a real physician,
Mhm.
that I could take anything on. And that's really why I chose it. But then, like I said, when I did the rotations, I found that the seniors were kind of like my jam. I really liked them.
Mhm.
So that's why I did the fellowship as well.
Okay, awesome.
Yeah.
Thank you for that. And give us a brief description of what family medicine physician does.
Yeah. So, like I said, so family medicine is really, we're the gatekeepers, right? So, especially in the world of insurance and all of these things, we did become the gatekeepers. We're the ones that have to like be the first to be seen. And we actually end up finding a lot of things that are missed, I feel, as well. Medicine has really changed, right? As you know, in terms of the way that we can practice due to the current state we're in with insurance and things of that avail. So I don't think that we're able to be the optimal physicians that we've trained to be with some of the restrictions that we have now. But we were the gatekeepers. I think we're still the gatekeepers. So we do everything, right? So we do that primary prevention, we do the acute care management, we do the long-term care. We do a lot of things. And with family medicine, you actually have a lot of routes that you can go into. So for me, I chose the geriatric route, but there was also people that would choose different things, like if you really love doing deliveries, because we also have to do babies, right? That's
Mhm.
part of life, is delivering babies. So I had to deliver about 100 babies when I was in residency as part of my training.
Mhm.
And so people that really like to do that, they could actually go out and do like an obstetrics almost fellowship as well. So they can actually do deliveries. A
Mhm.
lot of family medicine docs do that in more of the rural communities, right?
Mhm.
Because there's just no docs out there. So that was an option. The other option was sports medicine, right? So people that really enjoyed that part of their rotations had the option to do a fellowship in sports medicine as well, and to take that track. Um, but with family medicine, because we are kind of like the jack of all trades, there's a lot of people that would go in different aspects of their care and kind of focus on things like if they were better at derm, right? They would go into that more of the procedures and the derm and a lot of people open med spas or did the aesthetics portion of it too, because we had that training as well.
Mm.
So there's just a lot of, I think, options when you go into family medicine. You can focus on maybe even, the children, more of that, that care, or even adolescent medicine. That's another option that you can go into to kind of focus on, the younger people as well. You of course can become a hospitalist as a family medicine doc, right? So you can
Hmm.
still, you don't have to be internal, all due
Hmm.
respect.
Yeah.
You can go into, hospital medicine as well and become a hospitalist. So you could do urgent care, right? So docs that just want to kind of do what they got to do and then go home without a pager,
Hmm.
that's the option that you can have as well. So uh, you just have a lot of options, I feel, with family medicine as well, because you get trained in all aspects. So you kind of have more doors open for you, and you can go into whatever your passion might be. But then you don't always have to stay with it either. You can still, at some other point in your life, if you decide that you want to do other things. Like, so for me as a geriatrician, I did something called post-acute care.
Hmm.
So post-acute is like when people go from the hospital and they're still not well enough to go home. We've developed this new term called a skilled nursing physician or a sniffist,
Hmm.
right?
No.
And so that's what I did. I was a sniffist, and I would take care of people in that environment. So that's another option too. Um, and in those places too, there's things like wound care. So a lot of us go into wound care as well because of post acutes. There's a lot of things there. There's something called long-term acute care, or LTACs,
Hmm.
that people can also go into if they just don't want to be like in that hardcore hospital environment, but they still want to do some kind of almost like hospital care too. So that's kind of what I did. But then I've actually turned around and gone back to outpatient care. I started my own practice a couple of years ago.
Hmm.
It's called Vegas Direct Primary Care. Um, and the reason being is that because it's changed, right?
Hmm.
So people have to understand you don't go into medicine honestly anymore for this, right? Because the ROI is not the same. And we're talking a long time ago when people thought that we could make money doing this, right? This is like probably even before our grandparents' age. It's not about that anymore. If you're going into medicine, you have to know that you have to absolutely love it. You have to love it. It is going to be a lot of hard work, but at the same time, it is absolutely rewarding, right? I don't think there's any profession in this world that is as rewarding as what we do, right? So that's what some people have to understand, is that the reason why we make a lot of money when we come out of training is because we were in school for 14 years while y'all were getting paid,
Hmm.
even if it was 40 grand, whatever, right?
Hmm.
So we lost that opportunity cost. So it kind of makes sense that we make a little bit more when we come out. But on the flip side is we have a lot of debt, right? So people can't go into medical school without being afraid of debt. Sorry.
Hmm. Hmm.
And it's okay. It's good debt. Take out that loan. It'll be fine, you know? So, but it's extremely rewarding. It's different. That's why I started my own practice where I do kind of like a Netflix, right? So it's a flat monthly fee.
Mm.
And then people have all access to me whenever they want. The flip side to that is concierge care. And concierge is a double dip. People pay ahead of time for access, and then they still bill their insurance. I don't want to have anything to do with insurance. So
Mm.
we won't talk about
Yeah, yeah,
that.
yes. That's a very iffy, long subject in
Yeah,
general.
yeah,
That
that's a whole different show.
yes, that I don't think the current medical students, well, they should be aware that there. I mean, there will be
Absolutely.
insurance implications in their job, whatever they do.
Absolutely. And
Um,
and I think that's where kind of we really need to revise our medical education, is that billing and coding are a thing.
hmm.
They
Hmm.
are how we get paid in this country. And I hope that, the medical schools become more cognizant of it to start teaching sooner than later. But there are options out there too, like what I do, in terms of not dealing with it. Hopefully those options will be presented to our medical students and residents as well.
Mm, Thank you for that. And
Mhm.
what is the typical training path? Is it three years of residency,
Correct.
and you talked about fellowship afterward?
Correct. So with family medicine, it is 3 years.
Hmm.
And it's almost like a kind of like medical school with the different rotations that we have to go through,
Hmm.
and the different bylaws that the ACGME gives us, like the delivery of 100 babies. Those are some of the prerequisites of graduating from the residency.
Hmm.
Um, and the different programs that are out there for family medicine are a little dependent on which one you choose. So some programs are actually more focused on the rural medicine. Some programs are more focused on the urban medicine. And so you have to kind of do your due diligence to find out what that family residency focuses on. Mine was a very new program. So we actually had to rotate with the specialties. So, like when I did my obstetrics rotation, I did it with the obstetrics team at Northwestern,
Hmm.
right? So when I did my surgical portion of my residency training, I did it with the surgical residents at Northwestern because there wasn't enough of us in my program. It was only 4 per year.
Hmm.
So we didn't have a lot of those, large ancillary services. We jumped on with the other teams. So that could be good or bad, right? Depending on your personality. But you were actually with the real teams, right? Working with them and getting that first-hand knowledge. So the hospital medicine portion was with the internal medicine team.
Hmm.
ICU was with the ICU intensivist at
Mm,
Northwestern as well.
mm,
So there's different nuances when you do go into family medicine in terms of the residencies that you choose. You have to be
mm.
cognizant of as well.
Okay, awesome.
Yeah.
One particular question I like to ask, I mean, thinking back and why you chose family medicine, did you consider other residencies, such as, say, internal medicine, where you can be
Mhm.
a primary care physician?
Cardiologist. Yeah, yeah. So
Exactly.
yeah, so that was the thing. I think for me, yeah, definitely internal medicine was my other option.
Hmm.
I actually like the hospital medicine portion of it really too. So yeah, that would be the difference because with internal medicine, the specializations, you have more of the choices, right? So you could go into like the cardiology, nephrology,
Hmm.
neurology, things of that sort. So that opens more doors for the specialty route. Uh,
Hmm.
so um, that was probably my second choice. I was never a fan of surgeries. I like to talk to people. I'm super social. I don't need them asleep,
Hmm.
right? That
Yeah.
wouldn't make me happy. I like people to be awake, to be alert,
Yeah.
so we can chat and improve their quality of life. That's always my goal.
Mm. Okay. And then you talked about your personalities and things like that, but what are the general characteristics that would make for a successful family practice physician?
Yeah, so family practice, like I said, we're kind of the gatekeepers of everything, right? So you
Hmm.
kind of have to be ready to speak about everything. And a lot of people will come to you and confide in you.
Hmm.
There's a lot of mental health involved in family medicine. So that's another portion of it that if people enjoy, they don't necessarily have to go into like psychiatry and things of that. We do a lot of we do a lot of mental health because once again, people come to us first, right?
Mm.
So as a family doc, you try to practice to your full scope of care, and then when you feel like this is out of my line, then we refer. But a family docs are usually we're pretty social, right? We like to get to know people. We like to get to know their families. We're the ones that usually back in the days were the ones with the little bags that would go into people's homes, right? I do that again. I do house calls, so I have the ability to do that once again. But we're super social. I feel we like to be part of the family because that's why we're called family docs, right?
Hmm.
So we want to develop that rapport. So it's very important to be able to communicate with people. It's very important to be able to get to know people, and it's important to be a listener, right? It's not always about talking, it's about listening too. And I think the other aspect of what we do is we're educators,
Mhm.
right? So we need to be able to talk about anything and to kind of keep up with all of the journals and the data and be able to answer those questions that people have. So communication is super important. You just got to like people to go into family medicine. It's not for everybody. I get it, but you definitely have to like people. And you have to be able to talk to them. And as you can see, I talk a lot. So
Very informative, though. And what is the most exciting aspect of being a family medicine physician?
yeah, I mean, I don't know. There's always like amazing things that happen, right?
Mhm.
So when you are able to, like I said, be a part of the family, like I recently had something bad happen to my family. My father passed away, and
Sorry to hear
my
that.
own, yeah, thank you. My own people, I don't call my people in my practice patients because they're not sick, they're members. So my members, literally, when they found out, they reached out to me, they sent me flowers, they brought me, I mean, it was just a whole different world. But that's kind of the world of family medicine, right? It's that good old fashioned respect. It's that good old fashioned being there for someone kind of aspect of it. So that's been like the most rewarding for me to know that it's not just me taking care of you. My members take care of me too. So that's been super rewarding. And, helping people or just getting, people better and diagnosing them and picking up on things that even the specialists miss because we really know our people, right? Unfortunately, when you get 10 minutes with somebody, you can't gauge as to what's really going on with them. And so being able to do that, I think is absolutely amazing. And giving people hope and giving people comfort. I don't think doctors are made. I think we're chosen.
Mhm.
I truly believe that. And we have to believe that too. And hopefully we start believing that by empowering ourselves in what we have committed our lives to do. This is not just, reading books and paying for school. This is a calling. This is something that we were made to do. So people have to understand that it's going to be tough, but it's going to be worth it. And when you make it to the end, you'll understand what I'm talking about. The fulfillment of gratitude that people give you, or the fulfillment that you get from someone just saying thank you, is pretty amazing.
Yes, totally agree, and thank you for that. And
Yeah.
then on the other side of the spectrum, every specialty has their frustration aspect to it. What are some of family medicine?
Yeah. So I think um, we already touched upon it, right? The way that we are compensated makes
Mhm.
zero sense to me.
Mhm.
Zero sense. And I'm from another country too. I'm Persian. So, you know, going back home, seeing how it's done, coming here, going to different countries. I've traveled 40 countries. It makes no sense. And when I tell other people from different countries, they're mortified, right? How a third party will dictate our worth and what we can and can't do, right?
Mm.
The other aspect I think that's really frustrating as a family doc is that there's, rumors out there that we're not going to be around anymore. And the reason being is that because these third parties have equivocated our knowledge and our education and our experience with people who aren't,
Mm.
plain and simple, right? We know who they are, right? So I'm going to tell you a little secret. The word provider that is used so, broadly in every aspect of healthcare now comes from Nazi Germany.
Mm.
The word provider was used by the Nazis when they wanted to pretty much degrade the physicians. And they stopped calling them physicians and just generalized them and used the word provider. I have proof on that. I can send it to you.
Mm.
So that's how backwards we're going right now in terms of our abilities to be able to practice to our full scope of care. We're being equivocated to people with less training, less education, less experience. and we're being told by third party what our value is. So that's why I kind of got tired of complaining about it and did something about it and started my own direct primary care practice. And like I said, my job is also an educator, because my own, colleagues don't even know about these things, because we all get caught up in our own worlds and don't realize what's going on around us. So I'm hoping that with, the students and schools and things of that avail, we do start to become stronger together, because we are totally weak apart. We're not doing well with that. And if we make our voices heard, then, hopefully we can get that respect and autonomy back as well. And the compensation system just really has to change. It's just not making sense anymore.
Yeah, which is interesting because there's all these survey or data that shows there's lack of there'll be continued shortages of family practice and primary care, and yet all these things are making people not wanting to go into primary care.
Yeah. I mean, our compensation is one of the lower ones, as everybody knows. Our burnout rates are one of the highest. Way too many metrics are imposed on us because we are, jack of all trades, right? So there's constantly these metrics that are imposed on us that have nothing to do with quality. I mean, even the board certification thing, if people really look into it, they'll notice that the value that it had at once upon a time, I don't think is equivalent anymore. It's also become a political thing. So there's actually an organization now called Physicians for Patient Protection that is doing their best to educate our society as well as physicians to try to bring us together in order to relay these messages. People don't know what they don't know, right? They think that they're getting 10 minutes because, that's what they're going to get. They don't realize that we have been put into a position where there's 1,000 people depending on us, and there's only 8 hours in a day. And we have to talk about a lot of things. I mean, the family doc goes in and just sitting down, we've already got to talk to you about how you're doing that day, what your labs were, what your diagnoses are, what your medications are. And oh, by the way, doc, we get that too, right? That's like the biggest hard words as you're walking out the door. Oh, by the way, doc. And then we're told to do that in 10 minutes. So the medicine has changed, but we need to kind of stand up for ourselves so that we can make it better for our future docs.
Thanks for that. And what are some myths regarding family medicine that you think are unfair or untrue?
Some of the myths, I think, is that, I don't know, I don't know if this is like a big myth, but that because we are the jack of all trades, we don't have any specialties that we're good at, which is absolutely wrong. I just told you, right? So there's a lot of docs that will focus their practice on a special niche or something of that avail. So that may be one of the myths, that we just have too much, right? And we can't really know everything. Well, of course, we don't know everything, but we know a lot, right? Because we have journals and things like that we have to keep up on. And, we have to get boarded every 10 years and redo an exam from beginning of life to end of life care. I mean, that's insane. So, so there might be a myth about that. I think the other myth, honestly, is that we are very low paid. Yeah, we are, but you have so many opportunities to branch out and do side gigs and things like that, which actually makes you a better catch, right? So even if people want to go into clinical research, I did that for a few years too. I was a good catch because as a family doc, I had that broad scope of knowledge. So if they wanted to do a study about GERD, I could help them out, or diabetes, I could help them out, or hypertension, I could help them out, because that's kind of all in our scope of care too.
It seems you've had extensive experience with different practice environments. Can you discuss about those different environments and how has it shaped your work-life balance, such as that?
Yeah. So when I came out of my fellowship, I actually went straight to the VA because that seemed like a good fit, right? As a geriatrician, we've got a lot of seniors there. Unfortunately, it wasn't a good fit. So that system wasn't too good of a fit. And then in the midst of me starting out my life as a physician, I went to MBA school. So I picked up an executive healthcare MBA because at that time it was already starting to become medicine as a business, and I wanted to learn the language. But I didn't stop practicing. I still stayed in that outpatient environment, and then I also did work with the DoD, which is Department of Defense. I did outpatient care with them. And then from that world, I went on into going back into my geriatric world, which is the post-acute world that I was telling you about.
Hmm.
So I started doing post-acute for a very large HMO. I was the lead sniffist. So from that world, I started to go back into doing some assisted living visits, hospice care, was a hospice medical director, was the medical director for one of the rehabs in town as well, and started doing house calls again. So I've kind of dabbled in all of it. And then now that I'm in my own practice, I can do anything, right? I don't have any limitations. So I can do all of it. And I have been doing all of it. As a family doc, you can pick up a lot of side gigs, right?
Mm.
So some of the side gigs that I have is that I also do work with occupational medicine clinic, right?
Mm.
So in Las Vegas, we have a clinic that helps the individuals that are working at the casinos when they hurt themselves.
Mm.
There's an occupational clinic that I go and supervise.
Mm.
And then I also work with a plasma clinic. So plasmapheresis. I act as the center medical director for them,
Mm.
right? So there's a lot of opportunities that people don't know about. So maybe the myth there would be, yeah, as a family doc, you can only work in an outpatient and just see patients like that. Never.
Mm.
So much. There's so much. But you kind of got to be spunky and look for it too,
Yeah.
right? A
Yeah.
lot of things don't get handed to you, but I'm always like looking and observing, and the job boards that come through, I look to see if there's any other side gigs that I could pick up. And if I can, I do.
Mm. And it seems like this is a little offshoot, not so much a side gig, but it seems like I've met a lot of family med doc who does a lot of um, community service, international missions, and things like that.
Yeah, I do. So once a month, I go out to a clinic out here called Volunteers in Medicine, Southern Nevada. I
Hmm.
actually did the missions like in Haiti and Dominican Republic. And then I was like, why am I going over there? We need help in our own country. So I've decided to just bring it back home. I speak Spanish fluently, so I actually go to these clinics that are predominantly Hispanic, and I see them, you know, and that kind of is really what brought me back to medicine, was because I left. So that fire concept, I took off for a year. It was done with the whole, model, with the fee for service model. I was done. So I went and did a leadership course here with the Chamber of Commerce, and I developed my tribe, and I found this volunteers in medicine, and that's all I did was just see patients. I didn't bill, I didn't code, all of that nonsense. And I was like, I'm a pretty good doc. I need
Yeah.
to keep doing this. This is my passion. This is my life. Um, so I got the guts to open my own practice, and that's why I do what I do, is because, like I said, we're chosen. We're chosen, and it wouldn't be right to just walk away.
Okay. Awesome.
Yeah.
Thanks. And
Yeah.
you briefly touched upon fire. I follow that path, but the students may not know what exactly that is. Can you you can touch a little bit about that, because I think
Yeah.
it's really
So
important.
super important.
Mhm.
So fire is financially independent, retire early,
Mhm.
right? So I actually jumped on the bandwagon pretty late, but because I'm solo, so I don't have kids and the husband and all of that, so I could do this much more expediently. And it was just really knowing what I wanted in terms of my quality of life and being able to gauge what's important to me. I am a huge traveler. I'm passionate about traveling. That's what feeds my soul. So I just needed to make sure that whatever I did in my life was able to allow me to continue traveling. So I started listening to the podcasts, and like I said, I went to MBA school. I started learning about finances really early, and I absolutely recommend people learn about their money immediately. It's your money. You worked hard for it. You've got to make sure that it works for you as well. You can't just leave it in a damn bank and hope and pray that one day, you'll be able to spend it. So I just really started doing my research as soon as I could about how I could do this. And I started dabbling in real estate. So that's kind of what my retirement is, honestly. I don't have a lot of other insurance plans and things like this. I've really put my money into real estate and just some basic stock options that, that compound over time. And just listening to, White Coat Investor, things like that, it's been invaluable, and other like-minded physicians. People are helpful. You just need to ask. I think that's one of our problems as docs is we don't ask. We assume that everybody's busy. We assume that nobody wants to help you, and it's not true. And I found that especially in my DPC life is that the DPC family, we're really tight, and we are all over the nation. It's not like they live here or anything, but I can reach out to people and they offer help all the time.
Yes.
So yeah, get on it. Get on
Yes.
it.
Yes.
ASAP. You can pay off your loans and get help with all that stuff. And there's just so many options out there that people can fire. But it's a nice feeling, right? I work because I want to, not because I have to.
Yes. Yes. For the students, there is a huge online community that they can join. Facebook has a
Nice.
bunch of online communities about fire. So if you're interested, even if you're not interested in family medicine or whatever specialties, being financially literate is a very important aspect of living life.
Absolutely.
So thank you.
Absolutely, because like I said, when you're starting out, what would make like pennies on the dollar, but when you become an attending, it's going to be, a good amount that you want to, be responsible for, and know how to spend and not spend, right? So I think one of the lessons that we learn in fire is to live like a resident. As much as you can, live like a resident. Listen to me. You can't take stuff and things with you, you guys. You can't take stuff and things with you. It doesn't matter, right? Your quality of life is what matters. Your friends, your family, the memories you leave behind. None of the stuff and things matters. And I know maybe in your culture and my culture, we've got our own little nuances about what you wear and what you drive and what you live. That's garbage. It's all garbage. They lied to you, and don't do it. Don't do it. It doesn't make sense. There's no reason for you to carry a $5,000 purse. That is asinine. Don't do that. Right? Put that money back, even if you get 3% on it. Give me a break. Come on. So it's important. It's important. Spend your money well, but make sure you're smart about it because it's your money.
Thank you. And you kind of touch, I guess, getting back to the family medicine aspect, you kind of touch, can you touch base on what you think is the outlook 10 to 20 years as a family medicine physician? You kind of touch base on a little aspect of how it's already been changing. What do you think?
I am an optimist, so I'm going to say we're not going anywhere because you can't do what I do. What we need to do is keep our people and our society educated about the difference in training, and to be proactive of supporting these organizations like the one that I mentioned, physician protection for patients. Yes, exactly. So those things we need to come into like alliances so that we don't go anywhere. What we do is invaluable, and it's not the same as other clinicians in their training. So I'm trying to be as optimistic as possible, but I don't know. I probably won't be practicing in 10 years, to tell you the truth.
Hmm.
I mean, I actually also have a financial advisor. I know a lot of people don't like them, but it's, like I said, it's just me. So I need help. And I decided to take that route. But I mean, I could probably walk away within the next couple of years and be okay. Do I want to? No, of course I don't, because I've got people that depend on me and people that trust me and people that finally found someone that they trust too. So I would never do that to them. So I'm hoping that there will be more people like us, people like me, that are really in this practice for the love of medicine and to help people and to give them that quality of life and to be able to actually practice preventive care, because that's what we do. And that's not what we do in this country, but that's what we were trained to do.
Mm-hmm. And
So hopefully we understand the value of that.
understood. Thanks. You touched base on different, as I call it, everybody has different names, mid-levels, NPs and PAs.
Yeah.
And have you worked with them, and do you see their responsibility changing over the years?
Yeah, so I mean, when I started working with especially nurse practitioners, they were literally nurses once upon a time. So they had like a lot of patient experience. So they were there with us, right? Um, so I really have a lot of respect. The problem is that their training has changed too, to the point where everything they're doing is pretty much online. And then they turn around and they get something else called a DNP, which completely confuses our patients, right? A doctor and nurse practitionership. And if you look at the education, the doctor part has nothing to do with clinical skills. It's more of a social thing. They learn more about the social aspect of medicine, which is fantastic. Great, we need that. But don't walk into a clinic and identify yourself as a doctor and not confirm you're a doctor of nurse practitionership. That's where I get a little bummed about it, right? And unfortunately, I had to leave one of my job sites because I saw that happening. And I was like, that's unethical. That is completely unethical. And the person in charge was not in agreement and didn't think I was a team player, but that was not for me. I didn't need to be a team player in that sense. So they do have a role, and they have an important role, but their role is to be more of a complement and not to be something that takes over what we do. So unfortunately, various states do have them as being completely independent. Once again, I don't have a problem with that, but their training is different. Their hours of practice, we get hundreds of thousands of hours of practice, right? They get maybe tens of thousands. We have data on it, right? And the concept was that they will save money. Well, no, because if you don't have the experience and the knowledge, what do? You order tons of tests, you refer to all the specialists, you order the incorrect medications, people go to the hospital. This is not how we save money, right? So this is kind of the myth that has come across now. And like I said, these third parties that pay us have equivocated them to what we do. Well, I want to see a physician. Well, it's okay, you can see the NP. Well, it's not the same, right? So this is the struggle I have with especially family medicine, is the equivocation of our education and our experience and our knowledge base. And I'm happy for them to do their own thing, but take my medical malpractice while you're at it. Pay that.
Mm-hmm.
Be on your own, right? Because if hits the fan, they come after us. I'm not coming after them. So the physicians out there that are co-signing without knowing people, without going into this place of employment where this person you're co-signing for are really, really doing a disservice to themselves, to every one of us by doing that. You're selling yourself short, and you should be ashamed, honestly. This is what we don't want you to do. And if you get sued, you're going to get mad, but you shouldn't, because you shouldn't have done that in the first place. You're selling your license, and we've worked for it for way too hard. So there's a lot of education that needs to be done in terms of that world. Once upon a time, yes, absolutely. PAs still have to have physician guidance. NPs in most states do not. That's concerning to me. That's concerning to me. Their roles are important, but not to the point where we're being replaced by them. And even for students, right? You guys have to speak out. You are not supposed to be trained by an NP. You're not supposed to be trained by a PA. You're supposed to be trained by a physician. That is against ACGME rules for that to happen. And that's also happening. But the opposite of that is physicians are going into PA schools and NP schools and teaching. Doctors should teach doctors. Mid-levels should teach mid-levels. Plain and simple. And if we wonder why we're losing our fight, because you're helping the wrong side.
Okay, thank you
Yep.
for that. And
Yeah.
regarding the job market, like I said, it seems like there's all the data out there seems to be shortages of primary physicians. What do you think regarding
Yeah.
the job market in 5 to 10 years?
Well, like I said, if we are going to help our careers by promoting the differences and making sure that people understand the training matters, we will always have a job,
Mhm.
right? You will never not have a job. We're still physicians, we're still like, prime candidates for any clinical aspect. So if it's not the outpatient world, then we're just going to have to jump into the other worlds, right? And that's going to be a disservice to our society. I know that as a doc myself, I'm horrified of who's going to take care of me in the future. Horrified. I have no idea. And I'm hoping the best of the best still go to medical school and they're not afraid of it, like some people seem to be now because of all the stories that they hear about the struggles that we go through. It's still extremely rewarding. It's the best thing you can ever do. Being thanked for saving a life, invaluable. Who does that? Taking care of families, taking care of people, taking care of grandparents, right? It's important, and we need to keep physicians doing what we do. It's very important. We are the front line. We are the prevention. We are the acute care. We are the chronic care. We are all of it. So we need smart people that are devoted, that are, compassionate, going into family medicine.
All right. Thank you for that. And
Yeah.
what if people are interested, students are interested in learning more about family medicine? What helpful resources are out there for them to learn more about the specialty?
So, I mean, the American Association of Family Practice has several resources out there. I think that they should also start very close to home, right? So, talk to your own family doc, right? And see if you can do some shadowing and walk around with them one day or a week or something. I really don't think any of us would ever say no to that, because we want more, people to go into family practice. I would stay local first and just go straight to your family doc and ask them to do some shadowing. The American Association of Family Practice is invaluable sources as well. The hospitals, I don't know if people volunteer anymore, but if you're interested in that part of family medicine, you can do some, some volunteering as well. And also the our free clinic, Volunteers in Medicine. We have a lot of students that are pre-med and all of that are rotating there, and scribing.
Mm-hmm.
Scribing is an awesome way for people that are interested in medicine to make a little cash and be there in the heart of it. There's a lot of that going in the ER world, right? There's family docs that do ER too. You can do ER.
Mm-hmm.
Scribing is a really awesome way for the younger people to kind of get into the real bread and butter of what we do as well.
Yes, you're correct there that you can go and do ER residency through family medicine. There are programs out there that offer a 1 year fellowship for it.
Awesome.
And my last question is, what are your top tips to students who are interested in family medicine, and also anything else that you like to add that I haven't asked.
Okay. I think you've asked everything,
Yeah.
but so the top tips are family medicine's amazing, do it.
Mhm.
And if you want to be the doctor that kind of knows everything, right? Like the good old school family doctor, that's us, right? We know a little bit about everything. You're going to get exposed to every aspect of medicine, and you still have the ability to specialize, even if you don't do like a whole rotation in itself. You can still make your practice very niche, right? And you can do a lot of different things. And if you don't decide to even practice medicine with your family medicine, you are still very top quality material for different things like clinical research, occupational medicine, all kinds of different things that are out there that you are still, a lot of us actually do a lot of social media.
Mhm.
Those are the family docs that are out there because we're social. We like to be out in front. So I do a lot of news things, right? So my local news comes to me with all this COVID stuff. Like I'm on it. I'm the one,
Mm.
right? That talks about COVID. So you have a lot of different aspects that you can also do. You don't have to just be practicing clinical medicine, right? So eh, really, if you have an interest out there as a family doc, I feel like you're a better option because you do have that knowledge base of a little bit of everything too. So you have a lot of options and you should do it.
All right. Well, thank you, Dr. Ati Hakimi, for your knowledge, advice, and also discussion on things that is a little outside of medicine, but I think it's all interrelated. And I want to thank you regarding these aspects, and I appreciate your time.
Yeah, definitely. I appreciate your time too. Thank you so much.
Yeah, it was fun, and hopefully the students find it useful. All right, so thank you. That ends our discussion.